Well, hello and welcome everybody to today's webinar, an interprofessional approach to providing medication treatment for transitional age youth with opioid use disorder. My name is Michael Brubaker and I will be your moderator today. I'm an associate professor of counseling at the University of Cincinnati and look forward to joining you throughout this session. I'd like to take a moment to share a little bit about our overall organization and program that is sponsoring this event. Today's presentation is supported through a Health Resources and Services Administration funded project called Serving At-Risk Youth Fellowship Experience Specialty Training, or we call that SAFE-T. We're training 48 ethnically and economically diverse social work, mental health counseling, and psychiatric mental health nurse practitioner students to be competent clinicians preventing and treating opioid and other substance use disorders among at-risk youth and their families. So we welcome our participating agencies and other professionals nationwide to this event. Would also like to share that this webinar is produced in partnership with the Network Coordinating Office, AMERSA, and the Adolescent Expert Project by NORC at the University of Chicago, and it's also part of the Transitional Age Youth Webinar Series. We thank all of our partners for their support in this presentation today. Okay, so let's talk about some logistics here to make your day go a little bit better here and also after the event. So as we do prepare for today's session, we'd like to offer a few suggestions that we hope will make this experience most useful for you both during and after the session. So first of all, if you look at the bottom of the screen, you can you'll note that you can access everything for this webinar at that website, and that's both for now and in the future. So pro tip, hey, we do strongly encourage you to bookmark this site. So go ahead and copy that down and bookmark it so you have everything. Our team is going to send you a follow-up email later today that includes links to the PowerPoint slides, on-demand recording, a brief survey, and instructions to claim your free certificate of attendance. So I'd also add too, you're going to see this in the chat box. There's a link for a pre-survey that we ask that you actually complete that as well. So we're looking for you to complete a survey before and afterwards, and we will follow up 3 months later as you're available to participate in the survey, because we like to find out how this information that Dr. Yule is sharing with us today is impacting your work and your practice. So also you can ask questions and modify your audio settings through your GoToWebinar control panel and on your computer, on your computer or mobile device. Later in the session today, we are going to have a question and answer session, a Q&A session, and we ask that you hold your questions until that time, and we do look forward to responding to as many as we can. So now, I'd like to introduce today's speaker. Dr. Amy Yule, medical doctor, is board certified in adult, child, and addiction psychiatry. She is the director of adolescent addiction psychiatry at Boston Medical Center and assistant professor at the Boston University School of Medicine. Her research includes risk factors associated with the development of a substance use disorder in adolescents with psychiatric illness, risky behaviors in adolescent substance users, and treatment of substance use disorders when co-occurring with psychiatric illness. She has NIH funding to evaluate the impact of treating psychopathology in young people on subsequent development of a substance use disorder. And with that, I'd like to welcome Dr. Yule.
Yule, you're on mute.
Thank you. I just realized that. So hi, everyone. Hi again. I'm very excited to be here today to talk to you about an interprofessional approach to providing medication for transitional age youth with opiate use disorders. Before I get started, I do want to note my primary institutional affiliations that Michael mentioned, and also want to note that I have no conflicts of interest with commercial interests, and that I will be discussing off-label use of medication. And so today we're going to, in a kind of short period of time, cover a lot of information and hope to help you identify why it's important to discuss medication for opiate use disorders with transitional age youth, discuss medical and psychiatric comorbidity associated with opiate use disorders in transitional age youth, describe the roles of interprofessional team members when providing medication treatment to transitional age youth, and then also discuss strategies to increase youth engagement with medication for opiate use disorders, as well as evidence-based individual and family education and behavioral interventions for transitional age youth and their families. And before I get started, it would be helpful to hear from you, the audience, about your professional role as we think about everyone's role within an interprofessional team. So if you could take a moment to please respond to the survey, and then we'll review the results in a moment. Great. So it looks like we have a lot of non-prescribing therapists and paraprofessionals and people who are in other different roles within the healthcare setting, as well as a few people who are in a role of prescribing medications. So with that, Misty, I think it's not forwarding. There we go. So again, we're going to start with talking about why it's important to discuss medication for opiate use disorders with transitional age youth. And want to first review, I think, kind of sobering information. So I think we think about young people, we think about kind of health, longevity, promise, futures. And I think it's important to recognize that, that transitional age youth are not immune to adverse consequences associated with opiate misuse just because they're young. And so they, can have opiate use disorder deaths. And in this data is from the kind of that you see on the slide is from 2017. And you see that in 2017, there were 70,000 drug overdose deaths in the United States. Of those drug overdose deaths, 46,802 were opiate overdose deaths. And among those 46,802, 3,618 of those opiate overdose deaths were among people ages 15 to 24. 15 to 24. So it's, unfortunately, the reality is that, opiate misuse can be associated with opiate overdose deaths, and that these are happening in young people. So really important that we be thinking about and talking about medications with young people, since we know that medications for opiate use disorders really do decrease opiate risk and do save lives. So another reason why it's important to talk about this topic when we're with transitional age youth is that we know that opiate misuse peaks in prevalence in transitional age youth. And so this slide that you're seeing here is from a national survey where people go door to door and assess for substance use and mental health symptoms. And this is looking at data from 2019. And you see the percentage on the vertical axis, and then opiate misuse and opiate use disorders on the horizontal axis. And you see that kind of for both groups, the red bar is the highest, and the red bar represents 18 to 25-year-olds. So these kind of transitional age youth that we're talking about. And so we see that 5.3% of transitional age youth misused opiates within the past year in 2019. And among those, 0.7% had an opiate use disorder. And so if we do compare this to alcohol misuse or cannabis use, opiate misuse is less common, but again, opiate misuse is associated with opiate use disorders and associated with opiate overdose deaths, and so it's really important that we be talking about this topic. And so another reason we're talking about this in the interprofessional setting is that we really need the whole team to help us engage youth with an opiate use disorder in treatment. And so this is data from a survey. There we go. From a study that was done looking at retention and care, where they compared young people to older people. And so this looks at on the vertical axis are the percent retained in treatment. And so it's better, the higher line is better because that indicates more people retained in treatment. And then across the horizontal axis are months from kind of entering treatment. And you see that pretty quickly that there's a separation between the red and the blue line. And the blue line are transitional age youth, ages 18 to 25, and the red line are older adults over the age of 26. And these were all people who were engaging in a fairly comprehensive collaborative care buprenorphine treatment program. And you can see again that the young people were less likely to stay in care, that kind of quickly the line drops, which means there were less of them, less youth retained in treatment. And then among those youth who did stay in treatment, they were much more likely to test positive for illicit opiates than older adults. So they, among those youth who did stay in treatment, they struggled more in treatment with getting into recovery than older adults. So this is a really important population to focus on and to think about. And when we think about medication for opioid use disorders, not only does it decrease someone's risk of an overdose death, but it also helps them stay engaged in care. And so this is a study also looking at retention in care. And so on the vertical axis, you have patients retained in care, having kind of a higher line is better. And then also kind of on the horizontal axis, similar to the previous slide, it's looking at time, and this is time in days, and looking at to 1 year. And so this is looking at retention in care for 13 to 22-year-old patients who had an opiate use disorder. And what they saw was that those who received medication were much more likely to stay retained in care. So the blue line, which is again higher, and that's kind of better, are those youth who with an opiate use disorder who receive medication versus those youth who receive behavioral health services only. And so again, kind of one reason why it's important to talk about this in terms of interprofessional teams is it really does take a village, because we know that, not only is it harder for them to engage in care, they have a harder time staying in care, but they also have a harder time accessing medication treatment. And so this is looking at trends in buprenorphine receipt, people kind of receiving buprenorphine over between 2009 and 2018. And you can see, and this is divided up into different ages. And you can see that for all the lines, they're increasing, except for one group, and that's the 15 to 24-year-olds, where we actually see a decline in the number of 15 to 24-year-olds who are receiving buprenorphine for an opiate use disorder. So that's probably multifactorial, but I think what it says to me is we've got to really work hard to think about how our systems need to change to support them engaging in care, and that we need a lot of people kind of involved in their treatment to support them in receiving the medication. So kind of as they've already said, really think about, when I think about treatment for opioid disorders, INTE, really think that it requires a multimodal team-based approach where we have lots of different people working together to support a young person in making changes in their opiate use. And so that, when we think about kind of what treatment entails, it often entails medication, behavioral therapy, thinking about social supports outside of the office, and then also caregiver involvement or involvement of other people that are kind of part of the young person's life to kind of help them again with engaging in care and help them with making changes. So the team, when we're kind of trying to engage young people with opiate use disorders in care, what are some of the things that we should be thinking about as part of the assessment process? So kind of as we move forward, I'm going to talk about important things to consider when assessing a young person who has an opiate use disorder. And I think the first thing that we need to think about with assessment is really, we want to stay patient-centered and engage them around their concerns and also help them understand their opiate use disorder. So in terms of engaging them around their concerns, if we're not talking to them about what they're concerned about or kind of addressing, what brought them to the office, they're probably not going to come back. And so we want to really use kind of that reason that they came to the office to help increase their motivation to engage in treatment. And many of these youth, really have no history of substance use disorder treatment and don't have a sense of what treatment looks like. And so with older adults, they may have been to treatment several times, have a sense that this is the process in treatment, this is what I need to do. And so with young people, that's less often the case. And so we need to kind of help also provide education around kind of who's part of the team, and also help them understand what an opiate use disorder is, and also kind of which helps them better understand why you're making recommendations of treatment. So if you kind of tell them, you need buprenorphine or you need therapy, but you kind of don't engage them around kind of why they need buprenorphine or why they need therapy, they're probably not going to come back. And so really want to think about, again, engaging them about their concerns and helping them better understand what's going on and what they're experiencing. And a piece of that is also assessing for opioid intoxication and withdrawal. And when someone's been using opiates on a regular basis and develops a physiologic tolerance to opiates, and if they don't use opiates, they have withdrawal symptoms, it's really hard to kind of hit that in-between space where you're not kind of either intoxicated with opiates or withdrawing from opiates. And so when they're coming to treatment, it's important to be assessing kind of, where they're at in terms of their last use of opiates and kind of how they're feeling during the appointment. So if someone's coming into treatment and they're experiencing withdrawal symptoms, they may be quite irritable. They also may be anxious. They may also feel very kind of uncomfortable physically. And so I think it's important to think about that when you're assessing them. And if they're presenting with withdrawal symptoms, that's a clear indication that they do need medication to support them. We want to kind of try to quickly fast track them so they can access and meet with a provider who can prescribe the medication. And then also think about that in terms of the assessment and really prioritize what you're addressing in that appointment if they're, really uncomfortable or really anxious or irritable. And to also not take that personally. So, I think we want to be welcoming and then kind of recognize where our patients are at when they're coming into treatment. So on the flip side, they may also come in with opioid intoxication. And that doesn't mean that they're not kind of motivated or wanting to make a change. Again, as I mentioned before, it can be really hard to kind of time your use to kind of present in the kind of perfect state when you're coming in for treatment. That's why they're coming in for treatment. They need support to make a change. I think it's important to think about intoxication or assess for intoxication, because if someone has recently used opiates and is intoxicated or has a high level of opiates in their system, they may not remember much of what you're talking to them about. So kind of, again, really want to think about kind of prioritizing what information you're covering during that appointment, and then potentially kind of writing down information since they, again, may not remember what you talked about, or trying to think about, can I involve someone from their support system to kind of help make sure that they get the information they need from this appointment, and then also you get the information you need as part of the assessment. So again, kind of important to think about intoxication withdrawal, and these are some signs and symptoms to look for. Oops, just going to go to Philly. So sorry, there's a slight delay with kind of me advancing the slide. So the other thing to think about when you're assessing a younger person with an opiate use disorder is to also assess for other risky use. Polysubstance use is very common among young people. They're often using what they can access and using multiple different substances. And so when we think about risk, we know that polysubstance use does increase your risk of risk. And increasingly over the past 3 to 5 years, we've been seeing that kind of there's been other substances commonly involved in opiate overdose deaths. And so this was an analysis done looking at overdose deaths specifically among young people, and looking at other substances that were involved. And you see that between 2014 and 2020, there's a big kind of sharp increase in two different lines. And one is in benzodiazepines, are the dark blue. So kind of saw a really big increase in opiate overdose deaths in young people where benzodiazepines were also involved. And then there's also a real sharp increase in this gray line, which are any stimulants. And when the term stimulant is used in these kind of epidemiologic surveys or kind of studies, often that's referring to cocaine and methamphetamines, and that's generally not referring to prescription stimulant medication. And so when you see that kind of term, any stimulant, it tends to generally be referring to cocaine and methamphetamines. So again, with recent opiate overdose deaths, we're seeing that many young people have been concurrently using benzodiazepines or concurrently using cocaine or methamphetamines. And another thing to kind of think about in this context is a lot of the cocaine has been contaminated with fentanyl. So many youth will think that they're using just cocaine, actually be exposing themselves to fentanyl, and they're opiate naive, which then can increase the risk of overdose and an opiate overdose death. The other thing is that with benzodiazepines, sometimes benzodiazepines are actually kind of what someone might be getting off the street are actually pressed pills that do contain fentanyl. And so then, again, they're being exposed to fentanyl, or it is a benzodiazepine, and just benzodiazepines combined with opiates are increasing their sedation and increasing their risk of overdose. So the other thing to be assessing for and thinking about is medical comorbidity. We've seen a huge increase in the incidence of hepatitis C associated with the opioid epidemic, and that's thought to be related to intravenous drug use and sharing kind of the things that you use to prepare drugs to then inject them intravenously. And the age group where we have seen the kind of the biggest increase, an increase in 400% between 2009 and 2019, are among the 20 to 29-year-olds. So again, these lines are showing you cases of acute hepatitis C per 100,000 population between 2002 and 2017, and it's split by different ages. And you see that the highest increase is among people ages 20 to 29. And this is important to assess for because sometimes hepatitis C can be very motivating for patients. They may not be ready to stop their opiate use, but they may be ready to kind of address and treat their hepatitis C. And so we'll try to engage them in hepatitis C treatment. And as we're building a relationship with them, then also kind of see if they're ready to make changes with their opiate use. So someone doesn't have to be ready to stop their opiate use or stop their substance use to receive treatment for hepatitis C. It's important to remember that. The other thing that's important to think about is assessing psychiatric comorbidity among people with an opiate use disorder, particularly young people with opiate use disorders. And this is kind of an older study that was published in 2009 that assessed whether or not someone, an adolescent with an opiate use disorder, had a current psychiatric disorder. And 83% of adolescents in this study had a current psychiatric disorder. So really high rates of psychiatric comorbidity. And likewise, just as a medical condition can be very motivating as kind of a reason to engage in care, sometimes youth are very motivated to engage in care to address their depression or their anxiety, and they may not be quite ready to change their opiate use. And so, we work to engage them kind of to address their psychiatric disorder and also build a relationship and kind of work with them in a motivational way to address their co-occurring opiate use or opiate use disorder. And some of the common psychiatric conditions to be aware of that commonly co-occur with opiate use disorders and substance use disorders among youth include depression, bipolar disorder, conduct disorder, anxiety disorders, and then attention deficit hyperactivity disorder. And we'll think about how some of those disorders might impact use and engagement in care and kind of things that you need to think about with modifying treatment a little bit later in the talk. So now we're going to switch to talking about treatment for transitional age youth with an opiate use disorder. And kind of want to start with, briefly discussing medication for an opiate use disorder. So this could be kind of in and of itself an hour-long talk or an 8-hour course, but we'll kind of try to quickly touch upon some of the highlights that I think are important for people who aren't prescribing the medication for an opiate use disorder to be aware of. And so there are two different groups of medications for the treatment of opiate use disorders that are FDA approved. There are agonist medications and antagonist medications. And within the agonist group, we have buprenorphine and methadone. And the term agonist means that the medication activates as an agonist for the opiate receptor in the brain. And so what that does is if someone's been using opiates on a regular basis, if they don't use opiates, they have withdrawal symptoms. And so if they're on an agonist medication, then they don't have withdrawal symptoms. So we're kind of stabilizing the level of opiates kind of within their brain and activating that receptor and preventing them from having withdrawal symptoms. It also helps decrease cravings to use opiates. And then if someone does use opiates while they have this medication in their system, the medication is blocking the opiate receptor, so someone doesn't experience euphoria when they take the medication. So if they're on the agonist medication and they take heroin or fentanyl, they won't experience euphoria because the medication is already there in the brain, activating the receptor and blocking other opiates from binding to the receptor. So in contrast, we have antagonist medications, and that's primarily naltrexone extended release. And what that medication does is it blocks the opiate receptor, so nothing else can bind to it. So if you have naltrexone extended release in your system, kind of at a steady state or a steady level, and you use an opiate, the opiate can't bind to the opiate receptor because naltrexone extended release is there, and so someone won't experience euphoria. The tricky part with this medication is that someone has to have not been using opiates for a period of time to start this medication, because if you start this medication when you have opiates in your system and this medication binds to the receptor and quickly kicks off the opiates from the receptor, then someone will have fairly immediate opiate withdrawal symptoms, which are very uncomfortable, and they may kind of then be triggered to continue their opiate use. So in terms of a little more details about buprenorphine naloxone, I mentioned that it's an opiate receptor agonist, and it's actually a partial opiate receptor agonist, whereas methadone is a full opiate receptor agonist. And the difference between partial and full, practically speaking, is that there's less risk for respiratory depression. So someone's at less risk to, stop breathing if they took too much of their buprenorphine naloxone. So if they took kind of extra and took too much of it, they might be very sleepy and kind of sedated, but their breathing rate wouldn't change. And so it's, was designed to be potentially safer or less risky in a situation of overdose if someone took too much of their medication. So the other tricky part about this medication, though, is it's a partial agonist, and so it only partially activates the receptor. So if you have opiates within your system that are fully activating the receptor, and then you take this medication, the medication is only going to partially activate the receptor, and so you will have opiate withdrawal symptoms. So to start this medication, someone does need to be having opiate withdrawal symptoms, which indicate that they have low levels or no opiates within their system, and then to start this medication. So if you have low levels of opiates or no opiates within your system and you take the partial agonist, nothing's bound to your receptor, and so it will partially activate the receptor, stabilize your withdrawal symptoms, and kind of help you kind of stabilize. But the tricky part, again, is that people do need to be having some withdrawal symptoms. And I do find for young people that they often struggle with tolerating withdrawal symptoms. Withdrawal is very, very uncomfortable. And so they're often fearful about having withdrawal symptoms, or just really struggle to tolerate it. So sometimes that can make it a little bit difficult to start this medication. The other part is that this medication comes in a sublingual formulation, so it needs to be put underneath someone's tongue if you're taking it on a daily basis. And then we do have newer extended release options where someone can receive a once a month injection of buprenorphine. With young people, some of them may have taken, in an effort to kind of stop their opiate use, may have kind of taken a friend's opiate or a friend's buprenorphine, or kind of gotten buprenorphine from someone off the street. And it's important to remember, even though someone may have taken buprenorphine before, they may not know how to take it. And so I've heard lots of creative stories of how buprenorphine has been taken by young people who are kind of trying on their own to stop their opiate use. And so really important to review instructions on how to take buprenorphine naloxone when someone's coming into care. And if you're in a role of not prescribing the medication and kind of a patient is telling you, oh, it doesn't work, or I'm having side effects or things like that, it can be helpful to kind of inquire or try to figure out how exactly are they taking it, and are they taking it as prescribed? And sometimes, again, they're not taking it as prescribed because they're trying to do kind of something funny, or, aren't interested in making changes. It's just that they may have a misperception about how to take it, or maybe, again, they kind of didn't fully listen to the instructions when they first received the medication, and kind of, again, may not be taking it exactly as prescribed. So this is a medication that is approved for use with youth, ages 16 and above, who have an opiate use disorder, moderate or severe. And there have been several randomized control trials that have demonstrated that youth do well on this medication. They have decreased opiate use when on it, and that this is a safe medication for them. So it's important to kind of, again, to think about buprenorphine naloxone as a treatment option for young people with an opiate use disorder. And then kind of wanted to provide a few more details about, naltrexone extended release, which again is an opiate receptor antagonist. And we talked about how and why you need to be off of opiates for several days before starting the medication. And I think one thing that I kind of include a picture here of someone receiving the injection, just as a reminder, because I'll often hear from parents, well, just give them the shot, or kind of other providers, just give them the shot. And I just want to kind of say it's not a flu shot. So, it's not a COVID-19 vaccine. It is a gluteal injection, which is, kind of an injection into a large muscle. And so there can be some discomfort, but there's definitely kind of discomfort that's tolerable, but it's, more uncomfortable than a flu shot. And there is some muscle soreness. So it's This is also a safe medication for young people. We have less data, though, on its use in young people, and this is a medication that's only FDA approved for youth above the age of 18. We are often using this for youth under the age of 18. Frequently, if someone's been in a residential treatment program, has been off of opiates for quite some time, and is transitioning to outpatient level of care, sometimes this will be a medication that's used as an alternative to buprenorphine naloxone, just because someone doesn't have any opiate tolerance and has been off opiates for a period of time. I think people can get hung up on this FDA approval piece, and its FDA approval is important. But as a child psychiatrist, I will say that I'm often prescribing medications for which there is an indication, but it's not FDA approved. And so when we are prescribing medications to young people where we don't have FDA approval for the indication that we're prescribing it for, it's important that we be doing informed consent and kind of letting kids and parents know kind of what information we know about the use of this medication with younger people, what are the benefits and what are the risks. And then I just kind of wanted to include this slide that kind of compares, again, these 3 different medications that are FDA approved for treating opiate use disorders in adults. And then again, buprenorphine naloxone is FDA approved for treating young people ages 16 and above. And want to compare them in terms of structure. And so methadone is a very structured kind of medication treatment. There's a lot of restrictions around methadone. That's often something that we're not recommending as definitely not as first-line treatment for young people, just because you do have to go daily when you're first being prescribed that, and that can really interfere with youth doing the things they need to do as part of being an adolescent or young adult in terms of going to school or jobs or things like that. If someone has struggled, to maintain abstinence on other medications for an opiate use disorder, with kind of being in different levels of care to treat their opiate use disorder, and really haven't responded to kind of other interventions, I think it is important to think about methadone as a treatment option. But we generally are trying kind of buprenorphine naloxone first, or kind of naltrexone extended release first, or thinking about higher levels of care before we move on to methadone. But methadone is definitely a very safe and important medication to think about in the treatment of opiate use disorders. And so I do mention it when I am kind of talking about that we have 3 different medications to treat opiate use disorders. I do mention this as an option when I'm talking about transitional age youth about this. And then buprenorphine naloxone is kind of in the middle in terms of structure and restrictions. There kind of has been some loosening of restrictions around prescribing buprenorphine naloxone with, they have kind of taken away the requirement for formal education to get your X waiver to then prescribe buprenorphine naloxone, but you still do need to get an X waiver to prescribe buprenorphine naloxone, even if you don't meet the educational component at this time point. So there still are some restrictions around prescribing it. This is something that, generally when we're starting off this medication with a young person, they're initially for the first week or 2, maybe coming every 3 to 4 days, then weekly, and then we're spacing out appointments over time. We now also do have the option, though, of the extended release buprenorphine formulation that's a once-a-month injection. And then naltrexone extended release is the least structured and less restricted. So you don't need any special waivers or, kind of training to prescribe naltrexone extended release. And it's a once-a-month injection. So those are kind of just some things to think about. And when we think about these medications, really need to think about it in an individualized way, and kind of think about, where someone's at in their recovery, or kind of their process of change. We want to think about kind of what their opiate use has been like kind of recently and in the past, and kind of what kind of structure they need. So in addition to medication, as we talked about in the beginning, really needing kind of it takes a village to kind of help these youth make a change. It's really important to be thinking about structured evidence-based behavioral interventions. And there are several with strong evidence for their kind of use with young people with substance use disorders and with opiate use disorders. So these do include cognitive behavioral therapy, the adolescent community reinforcement approach, family therapy, motivational enhancement therapy, and then also contingency management. And I do include a reference down below that is a helpful guide that does cover kind of some of the principles of the theory behind these different behavioral interventions, and helps you think about kind of the differences between them. think one thing that we want to think about, though, when we're thinking about therapy for transitional age youth with an opiate use disorder, is we want to match the therapy with their readiness to change. So if someone's not ready to change with their use, it doesn't make sense to teach them relapse prevention skills. So if someone's ready to change their use and is ready for total abstinence, then we want to match our intervention. Then we'll kind of use cognitive behavioral therapy, which is teaching them skills building, relapse prevention strategies, and that's a good match for where they're at in their readiness to change. If someone's really not quite ready to change, then we want to be using motivational interviewing to kind of identify their internal reasons for change, to help build their motivation to change over time. And then we really want to be focused on harm reduction and decreasing risky use. So thinking about kind of making sure that if they are using opiates, they're using with other people, so that if they did have an overdose, there'd be someone there to get them supported, to call 911, making sure they know about naloxone, which reverses an opiate overdose, thinking about safe injection practices if they are using intravenously to decrease their risk of hepatitis C or HIV. So kind of, again, when we're engaging them with therapy, you want to match the intervention with their readiness to change, to make sure that it's a good match and that we're, meeting the patient where they're at, and, again, staying very patient-centered as we're engaging them in care. And then I think it's important to acknowledge that, some transitional age youth with opiate use disorders aren't going to be ready to engage in treatment and may not want to come meet with you. And so, if that's the case, often these young people are connected with, a lot of people that care about them. And frequently there are caregivers or parents or other family members who, are involved in their lives. And we can engage them, even though the young person's not ready to engage in treatment. And so one intervention to be aware of is the community reinforcement and family training intervention, which is CRAFT. And it's really targeted to caregivers to help motivate adolescents or young adults with a substance use disorder to engage in treatment. And so some of the things that this intervention does is that it helps build communication and problem-solving skills. So often families, where there is a young person with an opiate use disorder, are under tremendous stress, and often people aren't doing their best with their communication skills. And so, this does help with that and help with problem-solving. It also teaches parents principles of contingency management to reinforce behavioral change. So really thinking about kind of what are incentives that we can put in place to help motivate your loved one to make a change, and then how can you be consistent with consequences if they're struggling to make a change. And then another target of this intervention is to really improve a caregiver's emotional functioning. It's incredibly stressful, as many of you probably know, to have a young person with a substance use disorder, particularly an opiate use disorder. Many of these caregivers or parents are just living and somewhat paralyzed by fear that their young person is going to overdose and die. And that's very scary and very stressful. And so we want to make sure that the caregiver is taking care of themselves, because if they're not taking care of themselves and really struggling with depression or anxiety, it can be hard for them to do this work to kind of help push and motivate their young person to engage in treatment and to make a change. And, when we think about caregiver involvement, it's really crucial when working with adolescents and with transitional age youth with a substance use disorder, particularly an opiate use disorder. And it's tricky because you do need to balance confidentiality with family involvement. And for people over the age of 18, many of them will say, I don't want my family involved. I don't want to sign or release information. And so you want to explore that and try to find out kind of why that is. There are sometimes, some reasons why it may not make sense to involve family. But, frequently the kind of more common reason why a young person's reluctant to sign or release information is they may not be ready to change. They may be worried about disappointing their parents. And so kind of trying to make sure that we communicate with them about what information we would share. And release information is not an all or nothing thing and can really be broken up into different components. And so often I'll start with kind of, would be okay if you signed a release information to have your parents involved with scheduling, or kind of, can we share information with your parents about whether or not you attended a treatment appointment? When you talk about scheduling, they're often like, oh yeah, like, please let my parent be involved in kind of making sure that, I get scheduled for the appointment, or, I don't really want to deal with that. And then, if parents if a kid isn't coming to care, it's hard for us to support them in making a change. And that's really important information for parents to know. If they're coming to care, then there's a lot that we can do to support them in making a change. And so if we can get a release information just to be able to share, with parents, yes or no, your son or daughter is coming to treatment, that's a really important piece of information for parents to be aware of. And, parents can really play an active and important role in encouraging treatment engagement, facilitating treatment engagement, kind of making sure that the patient's awake to come to their appointment. They have kind of transportation to get to the appointment. They can provide incentives around appointments, such as kind of, their favorite coffee drink after they attended the appointment. They also can monitor young people over time. So a lot can happen between appointments. And so they're often a great source of information in terms of if there's been an adverse event between appointments, in terms of kind of letting us know what's going on with a young person. And then if a young person does fall out of treatment, they are also very effective and helpful in helping them re-engage with treatment. And so I think I want to make the point that a lot of parents, particularly if their child is 18 and over, when they try to get involved and support their young person in engaging in treatment, they often get the response, I can either confirm or deny that your child's in treatment here. And so that's incredibly off-putting to parents. And, often these young people are living with them. They're on their parents' insurance. They're really a big part of their lives. And so, even if a young person hasn't signed a release information, then, you can say that kind of, we may not be able to talk to you because there's not a release information on file. Is there information you want to share with us that you want the treatment team to know about? And parents can do that without a release information. So again, we want to think about the parents as partners, not as someone that we're kind of keeping out of treatment. And if a young person's not ready for their parents to be involved in their treatment, really, exploring and continuing to reassess over time what are the barriers and what's going on in the family such that the young person doesn't want their parent involved. And then I think, again, I've talked about it takes a village. And so in addition to medication and therapy, transitional age youth with opioid use disorders really need a lot of support in the community. They've often gotten really developmentally off track and may not have much structure or support or kind of have many peers who aren't using substances that can support them in making a change. And so we want to kind of think about kind of what are ways to increase involvement in pro-social recovery activities. So how can we get them involved in things that are fun, a place where they can get support and that are going to be safe and not involve substance use. And so, three things just to kind of three options, and there are many different options, for young people. But one includes self-help. And so, self-help includes mutual help organizations such as Alcoholics Anonymous or Narcotics Anonymous. And they do have young people specific groups. So important to be aware of that. It's free. It's often, it's available on Fridays or Saturdays when our clinics aren't open. So again, want to think about all the supports we can use and kind of call upon to help a young person in making a change. And then if you're working with somebody who's in school or is thinking about returning to school, it's important to know that there are educational settings that do provide more support for recovery. And there are recovery high schools, which are smaller, really specialized schools that are focused on working with youth who have a substance use disorder and working to make a change. And they provide kind of regular education as well as some recovery supports in the form of kind of group therapy or other types of treatment. And then there are also collegiate recovery programs that vary in structure that are becoming increasingly common across the nation. And then lastly, just want to, in the next 10 minutes or so, kind of talk about integrated treatment for transitional age youth with opioid use disorders and co-occurring psychiatric disorders. Since I talked about in the beginning that this is very common and frequently occurs, we want to be kind of thinking about that as we're engaging them in care. And so one thing to be aware of is that many people with a substance use disorder have a history of trauma. And so that's, definitely the case for transitional age youth with opioid use disorders. And so we should really be providing trauma-informed care for all patients, just given the high prevalence of trauma. And trauma survivors report distress in care settings related to trust, safety, and a sense of agency. And so we want to be thinking about those things as we're working to engage them in care. And there's kind of a phrase when we think about principles of trauma-informed care, the 4 R's. So, realize the prevalence of traumatic events and the widespread impact of trauma, recognize the signs and symptoms of trauma, and then respond by integrating knowledge about trauma into policies, procedures, and practices, and then seek to actively resist re-traumatization. And what are some kind of practical things to think about when providing trauma-informed care? These are things that I think about when I'm meeting with patients. I kind of actively always remind myself that really this is building trust over time. And so I'm actually often somewhat surprised when patients are really open with me at the beginning, because I know that, they don't know me. It's going to take time to develop a rapport and develop an alliance and develop trust with them. So just to keep that in mind. I try to provide care in an unhurried fashion. We all try to do our best. Sometimes we're running late in clinic. Sometimes there's a lot of other stuff going on. If there is something like an emergency that I'm trying to manage while also being in clinic, I'll be really upfront with patients about that, so they kind of understand why my pager is going off or why I might seem a little bit distracted. You want to talk about procedures before doing them. And so often I'll kind of introduce, when I'm meeting patients for the first time, really kind of tell them what this evaluation is going to entail. We're going to talk about, your substance use, your psychiatric history, and kind of, as they transition between different parts of the evaluation, we'll kind of be explicit in saying kind of, we're going to switch gears and talk about X. And then I'll also explain why I'm reviewing that or why I'm talking about these things as part of the evaluation. And then also important to validate and normalize concerns. And then, when there are choices, if possible, provide choices to patients to help them retain a sense of autonomy. So those are, again, some practical considerations to think about. Also important to recognize that even though many patients have experienced trauma, not all will go on to develop a trauma-related disorder. So not all are going to go on to develop post-traumatic stress disorder. But important to, again, be screening and identifying individuals who do have PTSD. When we think about integrated treatment, really important to be addressing both disorders at the same time. Sometimes there's a wish that we could just address one and then kind of the other disorder is going to resolve, but unfortunately it doesn't really work that way. One thing that can be important is to discuss commonalities between an opiate use disorder and a psychiatric disorder. One example of that might be an opiate use disorder and Cochrane anxiety. So with an opiate use disorder, people will have triggers and experience kind of increased cravings. With anxiety, people will have triggers and experience times of increased anxiety. For both those things, cravings and anxiety, they are when they happen, they're scary, they're distressing, but they will kind of decrease in intensity over time. And so, I think kind of trying to kind of, again, help patients see commonalities where they do exist as part of addressing both of these disorders at the same time is important. And then you also want to be maintaining a flexible treatment plan. Sometimes as one disorder improves or worsens, it's likely to affect the other. So sometimes we'll see as someone's opiate use disorder stabilize, maybe somebody has a history of bulimia nervosa, and as their opiate use disorder stabilize, then they have a recurrence of disordered eating patterns and they begin binging and purging again. So you need to continue to kind of be flexible in assessing for both disorders over time. And so this often, one thing that's helpful is to have frequent follow-up, because a lot can go on during the week or kind of within a month. And so when I am working with patients who have co-occurring disorders, I will see them more frequently than I will patients who have only a substance use disorder or only a psychiatric disorder. And because there's a lot going on, sometimes intensive case management is required. When we think about medications, again, I kind of talked about this before, but you really need to think about medications to treat both the psychiatric disorder and the substance use disorder. Kind of if you're only treating one of them, I wish that if I just treated your anxiety with medication that your opiate use disorder would resolve on its own, but that's not the case, unfortunately, often. And so really want to be thinking about medication for both disorders. And to remember that medication alone won't solve both conditions. And then I think another thing to be aware of is there's really limited research on medication for psychiatric comorbidity. And so when I'm thinking about, medication choices and what makes sense, I will, first talk about with the patient FDA approved medications for the psychiatric disorder as the first line medication choices. And just wish that we had more data on how to optimally treat these co-occurring disorders with medications, but it's a little bit limited. And then another thing to be aware of or cautious around is to be cautious with psychiatric medications when patients are still actively using substances. And this is really kind of around sedating medications and sedating substances. So, alcohol is very sedating. And so if you're prescribing a benzodiazepine and someone combines that with alcohol, and particularly if they're binge drinking, they are at risk for an alcohol overdose or a benzodiazepine overdose. And so important to be aware of that risk. Likewise, the same thing with prescription opiates or sedatives, or with if someone's misusing opiates and you're prescribing something that's sedating. And then when we're thinking about medication, really want to be kind of set a clear treatment agreement. And one of the things that I think is important foremost is that really we need to talk together about medication changes. And, if you're having side effects on medication, it's okay to stop it. But please let me know, even if it's between appointments. And then but really don't want you adjusting or increasing your medication without us talking about it first. And then also really want to avoid as needed medication, because this is a patient population that's often looking for often quick and immediate relief from their symptoms. And so, often have a little bit of a harder time with understanding or having a sense of when it's kind of the right time to use an as-needed medication. And so generally I try to avoid as-needed medications, but if I am using them, I'll be really explicit about this would be the kind of situation in which I would recommend you use this. And then I kind of do follow up with them over time and kind of see how they're using it. And I think I probably spend most of my appointment talking about medication adherence and following up and just talking to patients about how they're taking medications. So it's not enough to kind of say, like, how's it going with fluoxetine or Prozac? Is everything fine? Really have to kind of get into did you miss any days of taking the medication last week? How's the medication going? Any times when you may have taken kind of double the dose or kind of taken more than prescribed. And really, again, getting into the details around medications with this patient population. And when I'm first prescribing medication, particularly any medication where there might be a risk if they're still actively using substances and they're on this medication, or it's a medication with a risk for misuse, then I'll start with kind of a shorter prescription, and then increase the prescription duration over time as they're engaging in care and stabilizing. And so when I quickly touch upon a couple things to think about with Cochrane disorders, I think it's really important to also identify Cochrane disorders, because if they're not identified, patients are often perceived as being unmotivated or kind of less engaged in care when it's actually symptoms of a Cochrane disorder. And so if we think about someone who's really struggling with depression, they're often withdrawn, they have low motivation, feelings of worthlessness, poor concentration, low energy. And so these are things I think about with treatment considerations, thinking about engaging external support to help them with engaging activities since their motivation and energy is low, really writing down instructions because their concentration is poor, and then assessing safety in terms of suicidal ideation. Likewise with anxiety, sometimes people have poor concentration, sleep difficulties, irritability, low energy. And so when I kind of identify thought distortions and avoidant behavior, so sometimes they'll avoid things that are making them anxious, and they won't tell you about them, and they're not bothering them because they're totally avoiding them. And so that's, they do need to address some of these things they're avoiding to make progress in their treatment and functioning. And so want to work with them and address those issues. And again, with concentration, write down the instructions, build relaxation skills. And then lastly, thinking about attention deficit hyperactivity disorder, patients with ADHD, if it's not being treated, they may struggle with long groups due to hyperactivity. They may be inattentive in a therapy appointment. And so want to confirm that they're learning the information that you've covered in session. Also really important to write down instructions and help them with organization planning. So as we kind of think about an interprofessional approach to providing medication for TAE with opiate use disorders, really important for all providers involved in caring for these youth to discuss medications for opiate use disorders. We want to be using structural behavioral therapy and community supports to help them engage in care and change their opiate use. And psychiatric comorbidity is very common in this patient population, so we want to make sure that treatment is addressing both disorders. And so with that, we will transition to questions.
All right, how wonderful. Thank you so much for the presentation, so informative. I want to invite our participants to share some questions. I believe we've already gotten a few that are coming in. And while we're waiting for some more of those to come, I did want to ask you a question. So there's often perceptions about mutual support groups, and especially with teens and adolescents, transitional age youth. One of the questions that we commonly get is, is that really safe? Are mutual support groups safe for teens? And I know you had mentioned that there are special groups for that, but maybe even elaborating if there are special considerations for them, and then also particularly if they're taking medications.
Yeah, that's a great question. And so, yeah, I did mention that there are groups that are specific for young people. And so often that can be really helpful to find a young person's AA meeting. They often have more young people's AA than young people's NA to help them with engaging in care and feeling comfortable in a community. But when they have surveyed adolescents about kind of how they feel in attending self-help meetings, they have found that they generally feel safe. But there were 22, kind of one study that looked at this found that 22% of adolescents did report one negative incident over their lifetime. And so, negative things can come up, be it kind of intimidation or kind of, being threatened or something like that. And so I think with anything that you're referring your patients to, always checking in about how that's going and making sure that kind of if you're making this recommendation, that a parent's really, closely involved in kind of monitoring how that's going. So, definitely for the first few meetings, driving into the meeting, kind of waiting at the meeting, if the youth feel comfortable attending the meeting with them, but really kind of monitoring what those relationships are like and how that's going.
Yeah, I really appreciate that, especially as if you as a provider don't necessarily know that particular meeting, and then providing some ways that they might get some supports to get in there. It's great. So I wanted to ask one other question, and we'll have some other additional ones coming. The other question I had was really about the interprofessional work. And so you've really talked a lot about interprofessional roles, and I so appreciate some of the different components and thinking through what these different roles might be within the team, and your emphasis on how important it is overall. I wonder if you could take a moment to share with us, from your perspective as a prescriber, what really makes an effective interprofessional team?
That's another great question. I think one thing that makes an effective team is everyone kind of thinking about really about what's their role in supporting the patient and working together and being flexible. Often I may have a larger patient panel, and so, may kind of rely on the therapist to help us, seeking collateral sometimes or kind of helping with forms. But if it's a day when I have more schedule flexibility and, I know the therapist is busy, then I'm going to take on kind of doing part of that. Or I think another thing to think about is that often patients sometimes, I think I do have to acknowledge that as a prescriber, I hold a lot of power with a prescription. And so sometimes it's hard with this power dynamic for patients to feel comfortable expressing their ambivalence, or, they know often, especially with prescribers and opioid use disorders, we have a clear opinion that we want them on this medication. We're worried about them. And so again, it can be hard for them to express their ambivalence to me. And so often, in terms of working with a team, I don't expect the therapist to know exactly how to prescribe the medication, all of the side effects, but really love it when we can collaborate and coordinate such that they create a space where the patient can talk about kind of their ambivalence, or, something that the patient's having a hard time talking about with their medication, that they can use the therapist for support to discuss that. Or if they're frustrated with me because I didn't prescribe something that they wanted, kind of also to have that space to process that. So.
Great idea of communication and roles and teamwork all around. So let's see. So one of the other questions we have here is, can you tell us the reason why they mix naloxone with buprenorphine?
Yeah, that's a great question as well. So when you take a buprenorphine naloxone sublingually, you actually don't absorb the naloxone. And so they designed it in that way so that if people tried to inject, but if you inject your buprenorphine naloxone, you will absorb the naloxone and you'll feel really sick. You'll have withdrawal symptoms. And so they designed the medication that way to kind of try to decrease risk for misuse. And so naloxone is an opiate receptor antagonist, and that's what we use to reverse opiate overdoses. But when you take buprenorphine naloxone as prescribed, you're actually not absorbing the naloxone.
So interesting. Okay, so I think this might be our last question for our time here, and that is, can you say a little bit more about what other more secular recovery support groups might adolescents access?
Yeah, that's another great question. I mean, I think there are alternatives to 12-step mutual health groups, like so there, smart recovery is something that's becoming more common. I think there are also recovery communities that have been online that are becoming more common, especially in the context of COVID-19. And I think just really trying to think creatively about what as a young person, what were they doing before they started misusing opiates, what brought them joy, and trying to think about other ways to engage them in kind of re-engage with sports or engage in some type of volunteer activity, or kind of anything that's going to give them structure and where they get to experience pleasure, kind of help to decouple. Often when they are kind of heavily involved in misusing opiates, that's the only way they're experiencing pleasure. And so we want them to have the experience of doing other things that are positive and fun that don't involve substances.
I appreciate that. It's these pro-social activities that also have some really rewarding elements to their minds along the way. So great. Well, I think that's all the time that we have for that. And again, Dr. Ewell, thank you so much for your time today. As we go to our next slides here, I do want to again thank Dr. Ewell and also acknowledge our funder today, the Health Resources and Services Administration. And on our next slide, we're going to talk a little bit about just a few last-minute items that are on here. As a reminder, our team's going to send you a follow-up email later today that contains the links to the PowerPoint slide, on-demand recording, the brief survey. Please complete the survey, and instructions on how to claim your free certificate of attendance. If you want to access any of those things right now, you can actually go to that site at the bottom, which hopefully you've bookmarked by now, espert.webs.com/opiate-medication-treatment. And then last slide over here, just to look at, we have this is actually part of a larger series for transitional age youth, and encourage you to sign up for these other titles by going to that same link that you found on your screen, which you can see on your screen here. And with that, I am going to conclude today's webinar. And again, Dr. Ewell, thank you so much, and thanks to all of our participants here for joining us today.
And thank you to the audience. Really appreciate your attention.